Welcome, everyone. Today, we're doing a focused exploration of whole-body MRI, specifically its role in managing prostate cancer.
That's right. We've got a really detailed presentation to work through, slide by slide.
Exactly. And the goal here is to pull out the key insights for you, the radiologists, urologists, uro-oncologists out there who might be thinking about bringing WB-MRI into your clinical practice.
Our mission, if you like, is to really unpack this material, look at the crucial points, understand the implications.
And the insights we're discussing, they come straight from a presentation by Professor Patani. He's a consultant radiologist at Mount Vernon Cancer Center in London.
A real leader in the field.
Yeah.
Fellow of the International Cancer Imaging Society, member of the PIRDA's committee, ESMO guideline panels. His expertise really underpins what we'll be talking about.
Absolutely. And just before we properly dive in, we should mention Professor Patani's disclosures.
Yes, important for context. There's research support with Siemens Health and Ears, roles at Lucida Medical.
Speakers Bureau for Siemens and Bayer, honoraria from advisory boards too. And we might touch on some off-label uses of technology.
It's just about understanding the information presented.
Right. So let's lay out our objectives for this deep dive. What are we hoping you'll take away?
Okay, first off, we really want to highlight the limitations of the traditional imaging methods. Bone scans, CT scans.
Specifically where they fall short.
Exactly. In detecting bone mets accurately, evaluating treatment effects reliably, and really understanding the therapeutic consequences of what we're seeing, or maybe not seeing.
Okay, objective 2.
We want you to get a good handle on the whole body MRI protocols themselves. What sequences are involved? When are they typically used in prostate cancer assessment?
Makes sense. And third?
We'll focus on the indications for what we call next generation imaging, or NGI. That's PET scans, WD-MRI. When should we use them?
For detection, characterization, response assessment.
Precisely. And we'll look at the relevant clinical guidelines that touch on these advanced techniques.
And finally, number 4.
Critically, we need to tackle the ongoing challenges, the unanswered questions. How effective is NGI really proving to be in detection and response assessment? There's still debate there.
Okay, great. Objective set. Let's kick things off at that first case example on slide 7.
Right. So this first case, it's a 76-year-old man. He's diagnosed with high-risk, locally advanced prostate cancer, Gleason grade 5+5. So quite aggressive.
And the initial imaging?
A bone scan was done, standard practice, and it showed an equivocal lesion in the L3 vertebral body. Equivocal meaning uncertain, could be cancer, could be something else.
Creates a bit of a problem for staging and treatment planning, right?
Exactly. You need clarity.
And this is where WB-MRI comes in.
Yes. The slide shows how WB-MRI helped clear this up. We also see a T2-weighted image of the prostate itself, showing that locally advanced cancer.
So comparing the bone scan, which had that increased uptake at L3,
raising suspicion for METs,
with the spine MRI and the WB-MRI, specifically the B900 DWI-MIP images, what did they show?
Well, they suggested something different. While the bone scan lit up, the MRI findings were more consistent with degenerative change in the vertebra, wear and tear. Not metastasis.
That's a really crucial distinction.
It is, and it highlights this fundamental difference we need to grasp. Bone scans and CT, they're merely looking at the bone matrix, the structure, and osteoblastic activity. The bones react.
Which is an indirect sign of potential trouble.
Exactly. Whereas WB-MRI, especially sequences like DWI and also next-gen PET mate, like PSMA PET, they interrogate the bone marrow space directly.
Looking at the cells themselves.
Yes. Cellular activity, the environment within the marrow. PSMA PET targets specific receptors on the cancer cells. It's a much more direct assessment of the tumor.
Understanding that difference is key, isn't it? Which takes us right into slide 8.
Slide 8 has this helpful diagram. It lays out how these different imaging technologies relate to the actual cellular biology of bone metastases.
Based on that Coleman paper from Nature Reviews Disease Primers.
That's the one. It really helps visualize what each modality is actually seeing biologically.
So, as we just discussed, bone scintigraphy, bone scans, and CT, they primarily reflect that osteoblast activity, the bone structure.
Essentially the host response, the bone reacting to something.
But then you look at DWI and fat water imaging like Dixon on MRI.
Now you're assessing cell density directly.
Yep.
And the fatty environment within the marrow. You're looking at the tumor cells and how they're changing the marrow space.
And PSMA, PET.
That's targeting specific tumor cell receptors, PSMA. So again, a direct interaction with the cancer cells.
These distinctions are critical because, as slide 12 points out, they lead to limitations with the older methods.
Absolutely. Because bone scans and CT are often indirect indicators, our confidence in the true metastatic state can be, well, lower.
Yeah.
Are we really seeing all the disease, especially disease just starting in marrow?
And that uncertainty has real consequences.
Huge consequences. It impacts our ability to detect accurately, characterize fully, and assess response properly. And that directly affects therapy choices.
You might get false positives, thinking there's disease where there isn't.
Right. Or false negatives missing disease that is there. Both scenarios can lead you down the wrong treatment path, potentially causing harm, either through overtreatment or undertreatment.
And there's another issue, isn't there? Identifying non-responders early.
Yes. Traditional imaging might not pick up early that a treatment isn't working, so the patient stays on an ineffective therapy longer.
Delaying a switch to something potentially better.
Exactly. And racking up costs and toxicity without any real benefit. It really highlights why we need more sensitive direct imaging like WB-MRI. Which brings us neatly to slide 16, the protocols.
Okay, so Professor Patani groups the WB-MRI sequences into three main types of protocols.
That's right. Core, extended, and all-in-one. And the choice depends on the clinical question. Is it lesion detection, response assessment, full staging?
Let's break down the core protocol first. What's in that?
Okay. The core is your baseline. It includes sagittal T1-weighted and STR images of the whole spine. T1 for anatomy, STR for fluid edema, good for spotting lesions.
And for the rest of the body, skull base to mid-thighs.
There you're looking at axial or coronal T1-weighted GRE Dixon. Crucially, you must have the fat reconstructions from the Dixon data.
Why are the fat images so important?
Because normal marrow is fatty. Tumor infiltration typically replaces that fat. So comparing the fat and water images helps distinguish normal from abnormal marrow. It's fundamental.
Makes sense. And DWI.
Can't forget DWI. It's central. Axial DWI, again, skull base to mid-thighs, usually with SIDOR fat suppression. You need contiguous slices, no gaps, acquired in multiple stations.
And the B values.
Critically, you need at least two B values. Typically a low one, like B50 or B100, and a high one, B800 or B1000.
To calculate the ADC map.
Precisely, the apparent diffusion coefficient. High cellularity, like in tumors, restricts water movement, leading to low ADC values.
Okay, that's the core. What about the extended protocol?
The extended builds on the core. It usually adds more sequences, maybe different contrasts, and often includes dedicated coverage of organs like the lungs or brain.
And that's typically used more for?
Often for response assessment, where you need that comprehensive look. Maybe track specific lesions in more detail, or check for mets in other organs.
And the all-in-one protocol?
As the name suggests, it combines features for comprehensive staging, especially in high-risk primary prostate cancer. So it focuses sequences on the prostate and pelvis for local staging, plus the whole body metastatic survey.
A complete picture in one go.
That's the idea. And Professor Patani references the MATRAD-SP guidelines here published in European Urology back in 2017. They give practical advice on using and reading WB-MRI in advanced prostate cancer.
Good reference point. Now, slide 18 gives an example of an extended protocol.
Yes, a specific example using Siemens terminology. It shows that multi-station approach for whole body coverage.
And it gives some timings.
It does. Sagittal spine T1 around 2.5 minutes, STIR just over 2 minutes. Axial whole body T2 takes about 3.5 minutes.
What about the T1 VVE with fat fraction calculation?
That's pretty quick, about 1 minute, 20 seconds. VBE is volumetric interpolated breath hold examination.
And the crucial DWI with B50 and B900 plus ADC maps.
That takes the longest, around 7 minutes, 23 seconds in this example. And this extended protocol also includes brain images and breath hold lung images.
So quite comprehensive. And slide 19 shows the kind of images you get.
Exactly. Whole body MPRs, multiplanar reconstructions. You see stir haste, T1 VIBE, and the B900 DWI MIPs. Different views, different contrasts, showing the full body coverage.
Okay, now slide 20 touches on some important technical advances. Deep learning reconstruction.
Yes, DLR. This is a big deal. Using deep learning algorithms to reconstruct the MRI data, particularly for DWI, allows for significant reductions in scan time.
While maintaining or even improving image quality.
That's the key. You get faster scans and potentially better images. The slide cites a 2024 paper by Poncileone et al. On this.
How much faster are we talking?
Well, the example given is conventional DWI over 5 stations taking maybe 14 minutes versus DLR DWI taking about 6.5 minutes. That's less than half the time.
Wow, that's a huge difference in practice. For patient comfort, throughput.
Absolutely.
DLR algorithms are trained to reduce noise and artifacts. We see an example here. A patient with a high BMI, usually a challenge for DWI quality.
Right.
But the DLR version looks much cleaner, fewer artifacts. And in this case, that cleaner image apparently made it easier to spot pelvic and retroperitoneal nodes. So better diagnostic confidence, potentially.
So DLR makes WB-MRI potentially faster, more robust, especially in tricky situations.
Oh.
Okay, let's circle back to DWI itself. We keep saying it's key. Why is DWI considered the next-gen sequence for METS detection?
It boils down to what it's sensitive to. Tissue cellularity and cell membrane integrity. Healthy tissues have certain water movement patterns. Tumors, being densely packed with cells, impede that water movement. DWI picks up that difference.
And it works in bone and soft tissue.
Yes, that's a major advantage. It's not just for bone marrow. It can detect nodal disease, organ mets. It's versatile. Good for detection, for characterizing lesions, helping tell benign from malignant, and crucially for monitoring therapy response.
What about the practical side? Is it easy to implement?
It's getting easier. Firstly, standardization is improving thanks to things like METRADS, the reporting system for METs and prostate cancer. That helps ensure consistency.
Okay.
Secondly, DWI is available on pretty much all modern MRI scanners. It's fast, especially with advances like DLR. And a big plus, no ionizing radiation, no isotope injections like PET or bone scans.
And the quantitative aspect.
Huge benefit. Getting numbers, tumor volume, ADC values allows for objective tracking of disease burden and response. Plus, you can assess heterogeneity, see if some parts of a tumor are responding differently than others. That's valuable biological information.
Okay, really powerful. So when you're looking at a WB-MRI, what screams active disease? What are those typical features, especially on DWI?
Typically, active disease shows up as bright, high signal on the high B-value DWI images. That's the restricted diffusion. And correspondingly, on the ADC map, it'll be dark, low ADC value, meaning water isn't moving freely. And in bone marrow specifically, you'll often see a low fat fraction signal on the Dixon or VIBE sequences because the tumor cells are replacing the normal fatty marrow.
And you mentioned these quantitative metrics can even help guide biopsies.
Yes, exactly. Quantitative multiparametric assessment combining that high B900 signal, a low ADC, maybe less than 1100, and a low relative fat fraction, say under 20%, helps you pinpoint active tumor spots. This is super helpful for guiding biopsies, especially in sclerotic bone lesions where getting good tumor yield can be tough.
To get tissue for genomics.
Precisely. For next-gen sequencing, finding those active cellular areas is key to getting informative results for personalized medicine.
Makes sense. But then there's this point about the stromal response, the surrounding tissue reaction, potentially affecting the DWI signal. How does that work?
Right. It's a potential confounder. High DWI signal is usually tumor, but the intensity can be sort of modulated by what's happening around the tumor cells. Sclerosis, for instance.
Lung hardening.
Yeah. If you have widespread METs, but there's also a lot of reactive sclerosis in the bone, that dense sclerotic bone can itself slightly restrict water movement. So even with active tumor cells present, the DWI signal might look less intensely bright than you'd expect based on cellularity alone.
So you need to interpret DWI in context.
Absolutely. There's an example here. Locally advanced disease involved seminal vesicles, nodes, bones, lungs, widespread stuff. But maybe the whole body DWI MIP isn't uniformly blazing hot everywhere.
Okay.
If you then look at a pseudo-CT image, which shows bone density, and you see widespread sclerosis, that might explain why the DWI signal is somewhat dampened in those areas. You need to correlate sequences.
You mentioned pseudo-CT again. How do these specialized sequences or fusing images add diagnostic value?
Pseudo-CT, derived from sequences like UTE or ZTE or specific GRE sequences like the PDW-VVIBE here, gives you that CT-like bone density information. It helps differentiate benign sclerosis, like from arthritis, from malignancy-related mineralization or destruction, add specificity.
And image fusion.
Fusion lets you overlay different information visually. You could fuse the fat fraction map with the B900 DWI or the B900 DWI with the pseudo-CT. It gives you a kind of PTCT-like whole-body overview, combining functional or cellular info with structural context.
Useful for lymph nodes, too.
Potentially, yes.
All right.
Fusing the B900 DWI with high-resolution T2 images of the pelvis and retroperitoneum might help spot small, non-enlarged nodes that look suspicious on DWI. They might still need confirmation, maybe with PSMA-PCT, but it helps flag them. It shows how WB-MRI aims for that comprehensive, single-exam assessment, local, nodal, distant disease.
Okay, this technical grounding is really helpful. Let's pivot now to the clinic. Based on everything we've discussed, where does WB-MRI really make a difference? What are the key clinical indications?
Well, we've seen one already, characterizing those equivocal findings on bone scan or CT. That's a major one.
Right.
Then there's initial detection and staging, especially in newly diagnosed high-risk or locally advanced disease. Also, high-risk biochemical recurrence when PSA starts rising after initial treatment. WB-MRI can help find where the cancers come back.
Guiding salvage therapy.
Exactly. And evaluating oligometastatic disease, just a few spots of metastasis before trying metastasis-directed therapy like targeted radiation.
Okay.
It can also help with treatment planning. For instance, planning radiation boosts to nodes or oligomets if the patients had a good response to systemic therapy. Or maybe identifying patients who respond so well, they might need less adjuvant treatment.
And finally, response monitoring.
Hugely important, especially monitoring bone disease response, where CT and bone scans can be really tricky to interpret, particularly in castration-resistant disease. And using standardized criteria like MET-RADS, also useful in oligosecretory disease where PSA isn't reliable.
Let's dig into some of those indications with cases and guidelines, starting with newly diagnosed high-risk local advanced disease. That 76-year-old was initially N0 by conventional imaging. What do guidelines like ASCO say about using advanced imaging then?
The ASCO guideline generally starts with conventional imaging MRI of the prostate, bone scan, CT chest abdo-pelvis for initial high-risk staging. That's the baseline.
Right.
But they do say if clinical suspicion for METs remains high despite negative conventional scans, you could consider next-generation imaging like PE or WB-MRI. It might provide info that changes management, though they caution that the long-term outcome data is still developing.
And what do studies like PROP-SMA show in terms of real-world impact?
PROP-SMA was a big one. It directly compared PSMA-PCT against standard CT and bone scan for initial staging in men with unfavorable, intermediate, or high-risk localized cancer.
And the result?
PSMA PET-CT was significantly more accurate for detecting METs, led to more management changes, fewer equivocal results, less radiation dose. The conclusion was pretty strong. PSMA PET-CT could potentially replace conventional imaging for staging in this group.
So back to our 76-year-old M0 patient. PROP-SMA suggests that using something more sensitive, like PSMA PET or perhaps WB-MRI, might well have found disease missed by the standard scans.
It's quite likely, yes. Based on PROP-SMA and other data, a decent proportion of men staged N00 conventionally will actually have nodal or distant MITs picked up by NGI. Finding that upfront obviously changes the whole treatment plan.
What's the latest from the EAU, the European Association of Urology, on this, their 2024 guidelines?
The EAU 2024 guidelines now strongly recommend using PSMA PET-CT for staging high-risk localized or locally advanced disease if it's available. They still mention doing at least cross-sectional imaging and a bone scan, but the emphasis on PSMA PET reflects its proven higher sensitivity.
But they add a note of caution.
They do. Crucially, they state that the prognosis and the ideal management for patients found to be metastatic only on these more sensitive tests. Well, it's still unknown. That's key for everyone listening. We can see more earlier. But we're still learning exactly what that means long-term and how best to act on it.
A very important reality check.
Yeah.
Okay, let's talk about equivocal findings. Yes, a 55-year-old fit man needs a biopsy but already known high-risk features. PSA 3.32, Gleason 4 plus 5 suspected, abnormal DRE, PI-RODS 5 lesion on MRI. He wants curative surgery if possible.
But the staging is uncertain.
Right. The bone scan was equivocal at 2 sites. CT was negative. So is he metastatic or not? Critical question for surgical candidacy.
Slide 35 again references the ASCO guideline.
Yes, noting that NGI can be used to clarify equivocal findings or detect additional disease that might alter management fits this scenario perfectly.
So what did the NGI show? Slides 36 and 37.
Both PSMA PET-CT and WB-MRI were done. They showed uptake in a left internal iliac lymph node, plus multiple bone lesions, right acetabulum, 7th rib. These correlated with the equivocal bone scan sites. But importantly, The CT was still negative for bone mets.
Ah, so conventional imaging suggested maybe oligometastatic or even M0.
Yeah, but NGI clearly showed polymetastatic disease. Big difference in disease burden.
Which slide 38 emphasizes NGI clarifies tumor load.
Definitely. It can reclassify patients, often moving them from what seemed like low volume or M0 disease to clearly polymetastatic disease as seen here.
And this reclassification matters because management often depends on disease volume, right? Slide 40.
Absolutely. Think about trials like Charted or Stampede. They often classify metastatic disease based on CT and bone scan findings into low volume or high volume.
And that distinction influences treatment.
Hugely. Systemic therapy choices, doublet therapy like ADT plus an RSI versus triplet therapy adding chemotherapy like docetaxel, and also radiotherapy intent, radical versus palliative.
So low volume might get doublet systemic therapy, radical RT to the prostate, maybe adjuvant RSI.
Whereas high volume typically gets triplet therapy up front, maybe only palliative RT, and potentially lifelong RSI. Very different treatment pathways.
Which creates a real dilemma for our 55-year-old patient as outlined on slide 44.
Exactly. Based on conventional imaging, maybe he's low volume M1 or even M0. Based on NGI, he's clearly high volume polymetastatic.
So what about pelvic therapy? Surgery is likely off the table now.
Correct. Pelvic radiotherapy. Yes, probably. But should it be radical, aiming for cure, as suggested by conventional imaging, or palliative, as suggested by the NGI findings?
And this is the core dilemma, isn't it? Slide 45.
It really is. Do we change treatment based on NGI findings if we don't know if the prognosis of CT-negative PSMA-positive disease is the same as CT-positive PSMA-positive disease?
The EAU guideline point again, it's likely not the same prognosis because NGI is detecting it earlier.
That's the crux of it. We lack the data to know the true prognostic weight of these NGI-only findings.
Okay, so NGI often upstages. Are there situations where it's clearly not needed?
Sure. Slide 48 shows an example. Locally advanced cancer with obvious widespread M1b disease on the bone scan. Multiple lesions, high burden.
NGI wouldn't change management here.
Unlikely. The patient already has clear high-volume disease based on conventional imaging. NGI isn't needed to confirm that or alter the likely treatment plan.
But what about the flip side? Can NGI ever downstage someone?
Yes, that's an important point too. Look at slide 49. A 51-year-old man, high-risk cancer, and the bone scan shows a solitary bone lesion. So M1, but low volume by conventional imaging. The WB-MRI suggested the bone scan finding was actually just degenerative change. No sign of metastasis on the MRI. So the WB-MRI effectively downstaged him from M1 back to M0.
How often does that happen? NGI downstaging?
Slide 51 suggests the data is a bit sparse, but maybe around 10% of patients who get both conventional and NGI might be downstaged. It seems more common when conventional imaging shows only low-volume bone disease.
So maybe 1 in 4 to 1 in 10 men with equivocal or low-volume disease on conventional scans could be downstage to non-metastatic by NGI.
Something like that. And specifically down-risking from low-volume metastatic to just pelvis-localized disease on WB-MRI might happen in roughly 1 in 4 or 5 men in some series.
So the key takeaway from slide 52 is
NGI isn't just about upstaging. You can also downstage or down-risk patients. This really underscores its value in high-risk disease, especially when conventional imaging is negative or suggests only low-volume disease, because there's a real chance the NGI findings will change the proposed therapy one way or the other.
Okay, let's shift focus slightly. Slide 53 mentions high-risk biochemical recurrence and oligometastatic disease as areas where NGI is particularly useful.
Right. In these settings, finding the exact sites of recurrence or limited metastases is crucial for potentially offering curative salvage therapy or targeted metastasis-directed therapy, MDT.
How is high-risk biochemical recurrence, BCR, defined?
The EMBARK trial criteria, reflected in EAU guidelines, are often used. It's typically a PSA doubling time, PSA-DT, of 9 months or less, and a PSA level of 2 angiomellar or more above the nadir after radiation, or 1 angiomellar or more after prostatectomy.
And these men have a poorer prognosis.
Yes, high risk of developing widespread metastases. Treatment options include intensifying systemic therapy like adding in enzalutamide, considering local pelvic salvage treatment, or potentially stereotactic radiotherapy, SBRT, if NGI identifies isolated oligometastatic sites.
Slide 55 gives a case example of this.
59-year-old man, initially LABC, T3BN1, PSMA PEAT showed pelvic nodes confirmed at surgery. Later develops high-risk BCR with a very short PSA-DT of 2 months.
And NGI found the recurrent site. Slide 56.
Yes, both WB-MRI and PSMA PET-CT identified a solitary femoral lesion. This was then treated with focal radiotherapy alongside systemic therapy, abiraterone. NGI was essential for finding and targeting that oligometastasis.
Okay, and another important application. Treatment planning in low-volume metastatic disease. Slide 57.
Right. Here's a 60-year-old man, LAPC, pelvic nodal disease, and a solitary bone deposit found on WB-MRI. So clearly metastatic, but low volume.
What's the treatment plan here? Slide 58.
Because it's low volume, the plan is quite defined. Neoadjuvant ADT plus an ARPI like abiraterone or enzalutamide, the standard doublet, then curative intent radiotherapy to the prostate.
Potentially boosting the nodal disease if there's a good PSA response.
Exactly. Followed by adjuvant ARPI, a potentially curative approach despite the initial M1 finding.
And WB-MRI can monitor response.
The slide shows follow-up WB-MRI after neoadjuvant apalutamide. You can see regression of the bone metastasis correlating with a good PSA response.
And use it for RT planning too. Slide 60.
Precisely. The post-treatment WB-MRI can help pinpoint any residual disease, like in the nodes or the initial bone met site, allowing for targeted RT boost to those areas.
This links to ongoing research, doesn't it?
Yes, the STAR-TRAP study. It's looking at using SBRT to treat residual disease in patients with polymetastatic disease who've had a great PSA response to initial systemic therapy, or those with oligoprogression while on treatment.
And NGI is crucial for guiding that SBRT.
Absolutely essential. Studies like STAR-TRAP are vital to prove if these NGI-guided intensified treatments actually improve outcomes.
Okay, let's move to another major indication, response monitoring, especially in castration-resistant prostate cancer, CRPC.
This is a key area where WB-MRI shines, particularly for bone disease and CRPC, which can show mixed patterns on treatment. CT, bone scans, even PSA can be really unreliable for tracking response in this setting.
Slide 64 shows an example of CT limitations.
Yes. An 86-year-old man with metastatic CRPC, mCRPC, on treatment. His sequential CTs and bone scans showed stable sclerotic bone disease according to RECIST criteria.
So imaging suggested stability.
Right. But clinically, the patient was progressing. PSA was rising, symptoms worsening. And a WB-MRI confirmed widespread active disease progression within the bone marrow.
So CT completely missed the underlying progression.
CT only sees the interaction with mineralized bone. RECIST criteria struggle with bone mets because you can have marrow infiltration without matrix changes or progression happening within scarred sclerotic bone.
And distinguishing sclerotic progression from a healing response on CT is tough.
Very difficult. CT shows the matrix interaction, not necessarily viable tumor cells. And this is where MET-RADS comes in, the standardized WB-MRI reporting for response.
Precisely. MET-RADS gives us response assessment categories, RAC 1 to 5. RAC 1 is complete response. RAC 5 is definite progression. There are specific criteria. For bone progression, RAC 5, it could be new lesions, definite enlarging lesions, diffuse marrow infiltration developing, new soft tissue masses from bone lesions, or specific DWI changes meeting ADC criteria.
We saw an example of primary resistance.
Right. RAC5 on the first follow-up scan, new and growing bone lesions on WB-MRI despite treatment. Quantitative analysis can support this.
The example shows a quantitative total tumor load analysis. It confirms the RAC5 finding with a significant increase in the overall disease volume, while the mean ADC value remains stable, indicating ongoing high cellularity.
Okay, so that's progression. What about assessing response? Slide 75.
Now we're looking for signs of treatment working changes in soft tissues and bone.
Slide 76 shows a RAC2 example, probable response.
A 62-year-old man with mCRPC receiving docetaxel chemotherapy. The sequential WB-MRI show a marked reduction in the extent and the DWI signal intensity of his nodal disease. Clear signs of response.
What's the biological basis for these response criteria?
It relies on combining morphology, size, appearance, with functional information, primarily from DWI, especially changes in ADC.
So effective therapy kills tumor cells.
Right. This reduces tumor volume and cellularity. Dead or dying cells have leaky membranes, allowing water molecules to move more freely. This leads to an increase in the ADC value.
So rising ADC can be a sign of response.
Often, yes. Slide 80 details the specific response criteria for bone.
What do they include?
Things like return of normal fatty marrow appearance, a decrease in the number or size of lesions, sometimes evolution to a diffuse pattern change, decreasing soft tissue components associated with bone lesions, development of sclerosis, healing, emergence of fat within lesions.
And that significant increase in ADC.
Yes, typically defined as an increase of 40% or more, provided it correlates with favorable changes on morphology and DWI signal intensity.
Let's see some examples of good response. RAC1, complete response.
Here's a patient with MCRPC treated with enzalutamide. Baseline WB-MRI shows metastatic disease. Follow-up scan shows resolution of the bone metastases and return of normal marrow fat signal. That's a complete response.
Slides 82 to 84 show more examples.
Yes. Similar cases post-treatment, enzalutamide docetaxel, showing disappearance of bone lesions on DWI and morphology, confirming RAC1 response.
So the key point on slide 85 is
response assessment with WB-MRI relies on both morphology and functional criteria. It gives a much more comprehensive picture than conventional imaging alone.
What about complex cases?
This is interesting. Metastatic prostate cancer pre and post chemo, docetaxel ADT prednisone. Morphologically, the changes are a bit ambiguous. Maybe some sclerosis, but hard to be sure if it's response or progression.
But the DWI tells a clearer story.
Yes. The DWI shows a marked decrease in signal intensity, suggesting reduced cellularity, and the quantitative analysis on slide 88 confirms it. Significant reduction in total tumor volume, and a significant increase in the mean ADC. Clear response, even if morphology was tricky.
But ADC changes aren't always straightforward, are they?
That's a crucial nuance. While ADC often increases with cell death, sometimes effective therapy can actually lead to ADC decreases.
How come?
Due to repair processes kicking in. Things like sclerosis formation, dehydration within the treated area, myelofibrosis, or even the return of normal fatty marrow can all reduce water mobility and thus lower the ADC, even though the treatment worked. So context is key.
Response patterns can be complex. What about progression after initial response?
We see this too. A patient might initially respond well, go from RAC5 to RAC1.
But then later develop rapid progression again, slide 91.
Exactly, back to RAC5. We can also see discordant responses, some lesions responding while others progress. Slide 92 hints that genomic profiles might influence how quickly patients progress to CRPC even after initial response.
Okay, so WB-MRI seems better at assessing response, especially in bone. Is there trial data to back this up?
Yes, the RESPECT study looked at response monitoring in MCRPC patients.
What did it find? Slide 94.
It demonstrated that disease progression detected by WB-MRI using METRAD's RAC5 criteria was often completely missed by conventional bone scans and CT scans performed at the same time points.
Particularly for bone disease.
Especially for bone disease. About 75% of the men who were clearly progressing in their bones, according to WB-MRI, had that progression missed by their bone scans. A major discrepancy.
What about PSA? How well does it correlate with WB-MRI response?
It's variable. In metastatic hormone-sensitive prostate cancer, MHSPC, a deep PSA drop often does correlate well with a good response on WB-MRI, RAC1 or 2.
But not always in CRPC.
No. In MCRPC, it's much less reliable. The study showed many patients who were PSA responders, their PSA was stable or falling, were actually progressing according to their WB-MRI scans. So PSA alone is definitely not reliable for monitoring response in MCRPC.
Does METRAD's response predict outcomes?
Yes, data suggests it does. In MHSPC patients, achieving a RAC1 or 2 response on WB-MRI at 6 months was associated with significantly better overall survival compared to those with RAC3, 4, or 5 responses.
And again, confirming poor agreement between conventional imaging and WB-MRI for bone response.
Further supporting WB-MRI superiority in that context.
Okay, so WB-MRI seems technically superior for detection and response assessment in many situations, but slide 99 raises the big challenges and unanswered questions.
This is critical. Despite the better imaging, we still lack compelling high-level evidence, ideally from randomized trials, showing that making treatment decisions based on NGI actually improves patient outcomes like overall survival or quality of life.
That's the elephant in the room.
It is. We also don't know the true prognosis for those metastases detected only by NGI, the CT-negative, NGI-positive ones. How should we treat those patients? Do they benefit from the same aggressive therapies as patients with CT-positive disease?
Dilemmas we discussed earlier. And there's a risk of overtreatment. Slide 100.
Potentially, yes. Because NGI is so sensitive, it might pick up very small volume or slow-growing disease that might not have become clinically significant for a long time, or ever. This is related to length time bias. Are we just finding disease earlier without changing its ultimate course, but subjecting patients to more treatment?
And interpreting survival data comparing NGI-staged patients with conventionally staged patients is tricky. Slide 101.
Very tricky. You have biases like stage migration, lead time bias, and length time bias that can really complicate things.
Can you briefly explain those? Slide 103.
Sure. Stage migration, or the Will Rogers effect, is when better imaging finds more METs, so patients previously called non-metastatic get shifted to the metastatic group. This makes the non-metastatic group look like they're doing better because the worst case is left, and the metastatic group also looks like they're doing better because they now include earlier, lower burden cases. Survival appears to improve for both groups, even if no one actually lives longer.
Okay. Lead time bias. Slide 104.
That's simply diagnosing the disease earlier with a sensitive test. The patient appears to live longer from diagnosis, but their actual date of death might not change. You've just lengthened the time they know they have the disease.
And length time bias.
This happens when screening tests preferentially detect slower growing, less aggressive cancers, because those cancers are around for longer to be found.
And the consequences of these biases.
They can lead to inappropriate treatment intensification based on apparent stage migration, or even treatment denial if survival seems good enough based on biased data. And they generally overestimate the true survival benefit of earlier detection or treatment changes based on NGI.
So the bottom line is,
we desperately need prospective studies, ideally randomized controlled trials, RCTs, that demonstrate that the therapy changes prompted by NGI findings actually lead to improved patient outcomes, longer survival, better quality of life, fewer complications.
just finding microscopic disease earlier doesn't automatically mean treating it aggressively is better for the patient overall.
Precisely. The risk-benefit ratio needs to be proven.
Are these kinds of studies happening?
Thankfully, yes, several key RCTs are ongoing.
Like avidity.
Yes, Avidity is evaluating PSMA PET-CT for staging newly diagnosed high-risk prostate cancer. The endpoint is metastasis-free survival at 3 years. Will upfront NGI stagings lead to better outcomes?
And star trap.
We mentioned that one looking at NGI-directed SBRT for oligometastatic disease in various settings.
And P6.
P6 is interesting. It's assessing NGI-guided treatment strategies in MHSPC. It includes arms looking at de-escalating therapy based on excellent PSA response and escalating therapy based on NGI findings, trying to see if NGI can guide adaptive treatment for better outcomes.
So these trials are crucial for answering those big questions about NGI's clinical utility.
Absolutely critical.
Okay, let's try to summarize the indications for NGI based on current guidelines, maybe using ASCO as a starting point.
Okay, broadly. Consider NGI, WB-MRI, or PSMA PET-CT for newly diagnosed clinically high-risk, very high-risk, or locally advanced disease. If conventional imaging is negative, suspicious, or shows only low-volume disease, and there's high clinical suspicion or the result would change management.
What about biochemical recurrence?
For high-risk BCR, again, if conventional imaging is negative, equivocal, or low volume, NGI can help assess for local salvage options or find oligomets for MDT.
M0CRPC.
Mainly for detecting oligometastases in clinical trials currently, as the treatment implications are still being defined.
M1HHSPC. Metastatic hormone sensitive.
To clarify disease volume and distribution if upstaging or uprisking would genuinely change the chosen systemic therapy, for example, doublet versus triplet, or radiotherapy plan, including potential MDT.
And metastatic CRPC.
Primarily for therapy monitoring when clinical or biochemical progression is suspected, but conventional imaging looks stable or is unclear, especially in bone disease.
That seems like a reasonable summary of where things stand now. So let's recap the main learning points from this whole discussion.
Okay, key takeaway 1. Understand the flaws of conventional imaging CT and bone scans, especially for assessing disease presence and treatment response within the bone marrow. They are often indirect.
Second.
You need to consider the specific clinical scenario and the patient's overall prostate cancer state when deciding if NGI is needed and how it might impact management. It's not a one-size-fits-all approach.
Third, remember WB-MRI's strengths.
Yes, it's multi-parametric, combining morphology and quantitative data like ADC. And when findings are equivocal, using high specificity criteria is important.
Fourth, the big caveat again.
The potential for high sensitivity specificity imaging like NGI to actually change the disease course or improve patient outcomes remains unproven by high-level evidence. We lack those definitive prospective RCTs.
Which leads to the final point.
But critical need for those ongoing and future prospective clinical trials. They need to evaluate if NGI-guided treatment adaptations truly improve clinically meaningful endpoints while carefully addressing those survival bias challenges we discussed.
Excellent summary. Before we wrap up, is there a resource for listeners who want to learn more?
Yes, for those interested in really digging into oncological whole-body MRI imaging, the International Cancer Imaging Society website, isis.org.uk, is a great resource. They offer masterclasses and educational materials.
Fantastic. Well, that brings us to the end of this deep dive into whole body MRI for prostate cancer management. Thank you for walking us through that presentation so thoroughly.
My pleasure. It's a rapidly evolving field, and understanding both the capabilities and the current limitations of WB-MRI is crucial.
Absolutely. Comparing it to traditional imaging, understanding the protocols, the response assessment with MET-RADS, but also acknowledging the unanswered questions and the importance of the ongoing trials, it's a complex picture.
It really is. The landscape will likely continue to shift as results from trials like Avidity, StarTrap, and P6 become available.
Well, thank you for joining us for this in-depth exploration today. We hope this has provided you, our listeners, with some valuable insights into the current and the really rapidly evolving role of WB-MRI in managing prostate cancer.
Yes, thank you for listening.